what's the mix of GP trainees and obs and gynae trainees?
All obs and gynae trainees.
Okay, thank
all
you.
ST1 and 2.
Thank you. Right. With me accepting this tentatively, I suspect you already have realized my technical skills. So I'm just going to try and start presenting. Hi, everyone. I'm Suruchi Arora. Some of you, I don't recognize any of the names, actually. Some of you might know me, but I hide in a dark room because that's where fetal medicine happens. I've been asked to make a short presentation for fetal abnormalities. And what I've done is I have a mixture, really. I have a collection of some abnormalities. Of course, we can't go through everything, just to keep you interested, but mainly we'll also talk about what is your role and what is the other impact, outside of identifying the fetal abnormalities. So it's not just about finding a problem and finding a solution or not to it. It's also about the rest of the care. So that's where half of my focus would be, because that is how it is in clinics as well. Kind of half of the focus is on identifying if there is an abnormality, and the other half is on looking after the parents. So I don't know whether you can you see my slide?
Yes.
Yeah. Okay, and I'm moving it around as well somehow. I don't know how I'm doing that. Okay, so I'm going to put it on. Has it gone on to now? I can't see you either you guys or myself, so a bit disconcerting, but I just trust that you're just going to speak up if there is something going completely wrong here. Yeah.
Suruchi, I can't see your slides. Can everyone else?
I can see
we
can.
You can. Perfect.
Yep.
Then carry on. Oh, yes, I can. Ignore me. Carry on.
Okay, perfect. So as I said, I'm going to rely on you just stopping me. I can't see raising hands, or I don't know what's wrong, but anyway. So we'll start with talking about fetal abnormalities. So the idea of scanning a fetus is that sometimes we know that babies are born with congenital anomalies, and the idea is to be able to recognize these on a scan, which can include a 12-week scan and the 20-week scan. Of course, more recently, there is a lot of third trimester scanning happening as well. So the known incidence or estimated incidence of congenital anomalies is about 3% for all major anomalies. And please note here, we're talking about major anomalies. And this is a historical figure, and we need to understand that this is a dynamic figure. And perhaps we don't have true figures, at least not for now, because the research happens in past, doesn't it? As in the research is of the last 10 years, perhaps. What is the snapshot of this year might not be very visible. And the reason I say that is because with the incidence of scan resolution improving, and with the incidence of WES, which is whole exome sequencing, being introduced into testings, these numbers might very well be increasing. But in general, overall, known babies, when they are born, there is a 3% chance that there could be a major abnormality identified in the baby. And these anomalies that have been defined, they include malformations, they can include deformations, dysplasias, disruption of growth. There can be lots of different reasons for these anomalies that are identified at birth. Interesting phenomena is that this is the third most common cause of neonatal or infant death in developed countries. And so you can see the urgency and the relevance of it. The first two being prematurity and asphyxia. And yet, very importantly, it is not even in the top 10 for developing countries for cause of neonatal or infant death. So, the perspective needs to remain here. And this can be quite useful information to keep in mind, to bear in mind when we are talking to people who belong to different ethnic backgrounds, especially the ones who might have moved recently and might have a different cultural take on abnormalities and anomalies. So something to bear in mind. Okay, so that was congenital anomalies that we talked about, and coming to fetal anomalies, one would think, well, how can there be a difference? There is slight difference because congenital anomalies is something that the baby is born with. Of course, it will be present at the time of the baby being a fetus, but when they are diagnosed antenatally, they would be called fetal anomalies. Now, a question to be asked, is this number going to be higher or lower than the congenital anomalies? Well, what I say is that it could be lower than that because some of these anomalies might be missed because of resolution, some of them because of the BMI of the patient, or some just because they can't be detected, like anal atresia, cleft palate, or gut rotation, things like that. We cannot expect to see on scans. So they would be present at birth, but not, well, they would be present during the fetus, but we wouldn't see them. But also another take on this is that actually fetal anomalies, quite a few fetal anomalies are, the pregnancies are terminated before they reach to be babies. So the number could be lower in that sense. So overall, we think that the number probably is similar, as in that it's lower because of the pickup rate, but higher because of the terminations. So it probably standardizes at about 3% of pregnancies. This is just kind of to get an assessment of the numbers that we are thinking of and the workload. I'm sure you all are aware that etiology for any congenital stroke fetal abnormalities is multifactorial. They can be genetic abnormalities, they can be environmental, but quite a few of them are actually joint, that both the factors are contributing. An interesting phenomena here is that identical twins, concordance meaning that if we have identical twins, both of the twins affected by the same abnormality is about 20 to 45% depending on the abnormality. Of course, please note here that if there is a chromosomal disorder in identical twins or a genetic disorder, it would be present most likely, except for going into minor details of mitosis and meiosis, would be present in both babies. So if one baby has Down syndrome and it's known to be an identical pregnancy, then the other would have it as well. What we are talking about here is, say, if they have a heart abnormality, how likely is it that the other baby would have a heart abnormality? This is the figure for that, which is about 20 to 45%. And this figure is different for non-identical twins and non-twin siblings, which is about 3 to 5%. So that is an important figure, which means that if, say, somebody comes to you saying that my previous pregnancy had this abnormality, what is my chance that this baby is going to have a problem? Of course, it depends. The number is based upon what was the original problem, but a rough calculation can be about 3 to 5%. For the same problem. And this is on top of the 3% background risk of having a congenital abnormality of any other problem. So just a figure for you to know if you are counseling a couple about future pregnancies or current pregnancies when there was a past issue. And then when there is an affected parent, now this is something very important here, is that if either the mother or the father have been affected by a certain abnormality, there are some abnormalities that are not inherited and there wouldn't be any increase in chance, but overall, again, a ballpark image is about 3 to 5% chance of an affected child. Of course, if you're carrying an autosomal recessive disorder or autosomal dominant disorder, then that increases to 25 or 50% or 10%, depending on the penetrance. But that's a more detailed exam look into it. In general, it's about 3 to 5%. So you can counsel people like this. This specifically applies for cardiac abnormalities. So if some woman comes to you, oh, I was born with a hole in the heart, then you can say that this is the increase in chance for your child being affected. Another important point to say here is that this is related only to the mum and the dad and the siblings. So if somebody comes and says, my partner's brother's son had this problem, so now I'm concerned that my child might have it, usually, unless there is an inheritance in the family, unless there is a gene identified, usually that does not increase your chance, well, as in your patient's chance of having an affected child. So, this is an important aspect that sometimes couples come to you with, and you might be counseling people about this for future or for current pregnancy. Okay. So, then coming to what is our bread and butter, the most common major fetal abnormalities are, the top one is heart, and then cleft lip is the second most known. Don't ask me numbers. They sit somewhere around 1 in 1,000 for most of these major abnormalities. Down syndrome is obviously the most talked about and most invested in abnormality in our fetal anomaly screening program currently. And then there is spina bifida and anencephaly. So these are the ones that we would often see. When I say often, the chance is about 1 in 1,000. So we see about 6 or 7 maybe a year. I'm thinking we don't deliver 7,000 babies a year, but somewhere around that. And the most common minor fetal abnormalities are the kidney abnormalities, renal abnormalities. Having said that, they usually are just, they are the ones where you think, oh, kidney, okay, this is the easy one, I can sort that, I know what I'm doing. So that's but the chances of finding some kidney issue is about 1 in 400, 1 in 300. So, but most of those issues do not cause any postnatal impact. And so I thought we'll start with kidney because that is what we see most of. Now, I don't know whether how well you can see these slides, but this is a slide which is demonstrating a mild renal pelvic dilatation unilateral. What I'll do is I'll see if I can find an arrow here. Can you see my arrow? And this arrow is going to now show you, this is the cross section of a baby's tummy at the level where the kidneys are. So lumbar. And then this here is the baby's, I'm going to presume right kidney because I haven't labeled it, but that would be the right kidney. And this is how the pelvis is supposed to look like. But on the left side, this is how it looks like. And I've measured it to be 11 millimeters. That would be considered as mild to moderate renal pelvic dilatation. And it's unilateral. Then this is the kind of thing that we expect would most likely resolve spontaneously after birth, but we'll arrange postnatal scans for the baby and usually give a very positive outlook, and the baby should be fine and usually not associated with any other ill effects, either antenatally, intrapartum, or even postnatally. Then moderate renal pelvic dilatation. Now, let me see where my arrow is gone. The arrows disappear. So there's the arrow now, and then if I point it out, this is now a coronal section of the baby. You can see the back, you can see the spine here in long section. At the bottom, you can see the bladder, and this is left kidney, and this here is the right kidney. And you can see this black bit is the pelvis. Of course, on scan, everything that's fluid is black. So this here is the pelvis, and this is moderate renal pelvic dilatation. I haven't shown a measurement of this, but we would have measured and it would be more than 11 millimeters. And here what I want to show, what is very important, is called calyceal dilatation. And this is an important aspect when we find renal pelvic dilatation, is because our pediatricians have told me that this is very important to them. And calyces, as you might remember from the anatomy of kidneys, is that there is the renal pelvis and then there's the calyces that bring the urine into the pelvis. But if calyces are dilated, then that definitely indicates back pressure. And pediatricians are very interested in knowing about this, because if there is calyceal dilatation, then they like to give antibiotics, because this is a clear evidence of stasis for the kidney, which then means increased risk of infection. And if there is increased risk of infection, then increased risk of damage to the kidney, which is what we are trying to prevent. And the reason I bring this to you is because this is the relevance of basically fetal medicine abnormalities and looking for them. This is where it comes in place, that we can do prevention, because what we're doing is screening. We find a problem, and then what we do is make a plan for when the baby is born. If it's just mild renal pelvic dilatation, we just do scans to see what's coming off it and what could be the reason. And hope that most of the times it will disappear, resolve on its own. But if it doesn't, then we follow it up. But if we know that there is clearly cell dilatation, the baby is given prophylactic antibiotics from day one. So it does matter. And it's not all about finding babies with Down syndrome and, you know, having terminations and all that. So planning for the baby's birth and preventing any further damage is one of the major objectives rather of fetal medicine scanning.
Sorry, I have a question.
Yes.
Of those who the renal pelvic dilatation doesn't resolve after birth, what kind of problems do they tend to go on to have? Is it just that they've got reflux of urine, or?
Yeah, so it depends on whether they're a boy or a girl. Well, both problems can happen to both, but boys are more likely for this to be because of an obstruction. And if it's bilateral, quite often urethral obstruction. If it is unilateral, then it could be either pelvic-ureteric obstruction, or there can be uretrovesical obstruction. Now, it depends on what happens afterwards. That if this is just, it remains mild, then the baby remains under observations and can resolve, say, as they become bigger, because more and more fluid is drained through. So it's almost like flushing the tubes out. So if it's like a mild kind of thing, then the baby, in a way, we say outgrows the problem. Which basically could be that if there was a bit of gunge that gets cleared by itself, or if the ureters become bigger, then, you know, kind of whatever that little, of course, there couldn't have been a proper obstruction if there was a mild valve or something that just kind of resolves by itself. If it gets worse, then we have to do an MCUG, which is the dye, you know, we put in the dye IV, and then it goes through the kidneys, and you can see where the obstruction is. And depending upon the placement of it, I have been told, I have never seen this, but there can be laser ablation of whatever it is that's there. Of course, sometimes the cause is reflux, and if reflux is the cause, then we all know that we can't really treat it, but then we can be more aware of infections, and we can either, if it's quite bad, then the baby might need to stay on prophylactic antibiotics, or if it is not so bad, then we just need to watch for signs of infection. So whenever, if a child has fever, for example, we need to be more aware that as opposed to other children who might be having this because of a viral adenitis or something, this could be UTI. So just testing the urine as soon as possible, making sure that any further damage is not happening. And apparently from the reflux as well, which happens more likely in girls, they outgrow it most of the times, or they don't. If they don't, then they just have to either stay under surveillance, be very mindful of urine infections. As they grow, luckily they can tell for themselves, look for signs, but as baby we need to test their urine as soon as they get any temperature. Does that answer the question?
Thanks very much.
Okay, so this here is a picture of a moderate renal pelvic dilatation, because it's measuring 17 millimeters, but there is no calyceal dilatation. And interestingly, this is what is called a keyhole bladder. That's what we would be looking out for. Can you see the shape here? So keyhole, yeah. And this is a typical sign of a urethral obstruction. So of course, partial urethral obstruction, because if it was complete, then the bladder would be, you know, very big. That kind of complete urethral obstruction would actually we would identify that very early on in the pregnancy, probably around 12 weeks, with a bladder that's filling the whole abdomen. This is partial urethral obstruction. And this is an important sign to be looking out for, because if we tell that pediatricians that this is the case, then they will be very much giving antibiotics to the baby and watching the urine, that the baby passes urine normally, and if it doesn't, and scanning the baby before they go home, and then arranging an MCUG and perhaps preparing the couple for an ablation. But I am told, I haven't seen it, but it happens more likely in boys, but then it's easier to treat in boys as well, because obviously urethra being external, we can just put in a catheter, and laser ablation for the obstruction can be performed. We've already talked about what to do. Usually good prognosis with renal pelvic dilatation, but obviously it varies from just needing one postnatal scan and it being resolved to needing bladder surgery at birth for PUB. So, varied prognosis depends upon all these findings. So as you can see, it can be renal pelvic dilatation, but one couple might be going through a very different pathway and a very different discussion and feeling very differently about it to another couple. So, realizing that the same name doesn't necessarily mean the same kind of prognosis. This is an interesting one. Everybody likes this, so I've got a picture of it. You might think, why have I chosen some problems and not the others? Of course, we can't discuss all. So A, the ones that the pictures were easily available, and B, the ones that look very exciting. Sorry, baby. But so this is gastroschisis, where basically there is a little defect in the anterior abdominal wall, usually lateral to the umbilicus, to the umbilical artery entrance, and usually more likely on right side. And from that, small bowel are kind of hanging out. So this here, can you see my arrow? My arrow is pointing at the moment to the abdominal circumference here. Transverse section. This here is the baby's stomach, and this here, as you can see, is bowels that are outside of the baby's tummy. And this is the long section. This is a 12-week baby, and you can see there's a kind of sagittal, it's not quite sagittal section, but you can see a cauliflower-like growth. This is not a growth, it's just the gut that's hanging out of the baby. This is a 3D picture. Oh, baby. So there's the bowels here. So of course, with gastroschisis, if you think about it, it's a very simple, it's a very dramatic appearance. And so that's one starting, but then it's a simple solution that when the baby is born, you just push the gut back in and then close the defect. Very simple. But there are risks, which are that bowel can get strangulated. It's just like any hernia, really, where the bowel can be strangulated if the gap through which it's coming out is very narrow. Sometimes the bowel being exposed to the amniotic fluid outside can get damaged sometimes. And sometimes if it doesn't get strangulated, but it kind of keeps going in and out, a bit of it can get twisted and turned and lead to obstruction. So that's one thing that we will be watching out for. So although the prognosis is mostly good with gastroschisis, which is written here, sometimes about 5 to 10% of cases, there can be further damage that happens to the gut while the baby is waiting to be born. And if that happens, then sometimes we have to take away that part of the bowel away. And depending on what the length of it is, baby could have short birth syndrome. But the good thing is that gastroschisis is usually isolated and not associated with other chromosomal or genetic syndromes. So that's good, because there are certain conditions which kind of shout out to us saying, oh, if you find an omphalocele, for example, there is a high chance of it being associated with Down syndrome. So we would be talking to the couple about an amniocentesis, because the prognosis will depend upon whether there is an underlying disorder or not. but gastroschisis, luckily, is an isolated abnormality. Of course, delivery would be planned for tertiary center, but knowing also when we plan this kind of a thing is that it doesn't always work like that, because if the woman lives about 10 steps from here and goes into labor, which often they do when they have gastroschisis, then the first place for them to come is to this hospital, and sometimes intrauterine transfer is not possible. If that happens, we cling film the gut with the baby, and then we send the baby to tertiary center. But the prognosis is mostly very good.
Can I ask a question, Miss Aurora?
Yes.
What, with gastroschisis, what is the ideal mode of delivery? Because I would have thought a vaginal delivery, there's some risk of doing damage to that exposed bowel with compression through the vagina.
No, vaginal delivery completely acceptable and the preferred mode of delivery, because gastroschisis, because gut is so, like collapsible, flimsy, and it's coming out at the level of the abdomen, and abdomen is the easiest delivery point, isn't it? Like once the shoulders are out, after that the baby doesn't even give you a chance to catch him. So the gut just comes with it, so it doesn't have increased risk, no. While the baby is inside, it's well protected. So it's considered. Actually, most babies do deliver vaginally with gastroschisis.
Thank you.
If it was an omphalocele, on the other hand, if it's a large omphalocele, because omphalocele is in basically like, it's almost like a pebble on a pebble. So it's like you would see. Let me go back to this image. In an omphalocele, what you would find is that it's basically the peritoneum as well coming out. So the gut is not hanging like gut, like little flimsy particles. It is a formed mass in front of the abdomen. So it will be almost, where's my arrow gone? It is an abdomen circumference like this, and then there'll be another little mass in front of it. And that can sometimes be a space occupying lesion, if you know what I mean. So that can sometimes require delivery by cesarean. If it is large, that is. Otherwise, even that can be delivered vaginally.
Thank you.
Okay. Now, believe me, what you're looking at here is normal lips. Let me try and see if I can show you. You can see my arrows. If you follow my arrow, we're here. Can you see my arrow? And then this bit here that you see is the baby's mouth. There's the tip of the nose. This is a nostril. This is another nostril. This is baby's upper lip here. This is the mouth. This is the lower lip, and this is the tip of the chin. So we're looking at just this bit of the face, angling the scan onto here, just here. So that's normal lips, and this is one of the views that we are supposed to get in order to ascertain that the baby does not have hair lip, because hair lip or cleft lip, and this is how cleft looks like. We're looking in this area here, and if you compare this with the previous image, are you with me, or do you want to look at the previous image again? I'm presuming you are with me. So this here is the upper lip. Can you see the lower lip? We can see the lower lip. That's the lower lip here. There's the chin, there's the lower lip. That's what is supposed to be the upper lip, but there is a big gap here. Yeah, and that is a cleft. Now, this is a rather large cleft. We have seen much smaller clefts as well, but this one is quite large. Now, cleft lip is usually an isolated abnormality, and as I'm sure you all are aware, a surgically correctable abnormality as well. Of course, cleft lip can sometimes be associated with cleft in the palate as well. And that can sometimes cause bigger problems and more surgeries are required. But if it's just cleft lip, then basically, apart from needing support early on during the postnatal period for feeding, and then repair in a month or 2 months' time of the cleft. Apart from that, it doesn't have any other implications. So cleft lip is often either left or right, sometimes can be bilateral. Very rare to be bilateral, but it can happen. And usually isolated and good prognosis with surgery at 3 months. May or may not be associated with cleft palate. And of course, the presence of palate can change the treatment length. Now, in order to assess the palate for the baby, we used to, John Radcliffe Hospital, our tertiary centre, had started offering all cleft lip babies an MRI to look at the palate. It was during, well, all fetal medicine doctors, I mean, it was a part of research studies, to be honest with you, to study the relevance of doing these MRIs beforehand. It was always considered a bit doubtful about the relevance and the significance of that kind of intervention, but it was a non-invasive intervention, so it was agreed that that can carry on. But during COVID periods, with the MRI availability and of course reducing the amount of time that people are attending hospitals, this was withdrawn and has not yet been reintroduced. And I wonder whether it will ever be, because knowing whether there is a cleft palate or not does not change the management of the pregnancy. And it is very simple when the baby is born to open their mouth and see if they have cleft palate or not. So really, for such a simple thing, it is debatable at best to know whether calling a pregnant woman into a hospital and putting her through an MRI is the right choice. Having said that, we noticed that when it was offered to people, some people did say that it did help them be prepared, be mentally prepared. So there are both sides of the story. But at the moment, it's not being offered. So if there is cleft lip, and cleft palate is not something, unless it's large, it's not something that we can definitely diagnose or rule out by antenatal scanning. Now, one important aspect to note is that the location of cleft lip is important. If the cleft is either side, then it's usually isolated and with good prognosis. But if it's a midline cleft, and so it is important to know where this cleft is. If it's midline cleft, which is very less likely, thankfully, but it can be associated with trisomy 13. So I would have a very high suspicion if I saw a midline cleft and would offer an amniocentesis to the couple to find out if they had underlying genetic disorders, because of course that then changes the prognosis considerably, because the cleft is the same, it can be repaired in the same way, but the location somehow indicates likely association with trisomy 13. Because trisomy 13 is actually associated, most of the problems with trisomy 13 are to do with the midline, all through the midline, and in the brain as well, corpus callosum. Okay, so coming on to cardiac abnormalities. Now, again, the relevance is, I bring on the same theme here that we talked about kidney abnormalities, and they can vary from very minor to very, quite significant. And the same way is with cardiac abnormalities. They can vary from very minor to quite significant, even, well, kind of lethal abnormalities. I'll explain to you why I say kind of, because, with medicine evolving every year into better and better care, more and more fetal abnormalities are changing their category from being lethal to perhaps just being serious. And we'll come to that in a minute. So this is a picture of a right aortic arch, which is a minor cardiac abnormality. You don't have to be judgmental about yourself if you can't see at all what this is about. I'm just putting in a picture just to give you context that there is a right aortic arch, which is basically probably an aberration of normal. Quite a few of us supposedly have this that the arch, instead of being on the left side, is on the right side. When that happens, it crosses the trachea. For those of you who might have done some scanning, there's the trachea in the middle between the pulmonary artery and the aorta. The aorta should stay on the left side, but it has traversed to the right side, and the arch. And then when it comes down, it's going to travel in front of the trachea, which can sometimes give stridor to the baby. And that's the only problem that we can anticipate. Having said that, sometimes it can be associated. So this is the dilemma of fetal medicine, is that when you find this problem, very good prognosis, most of the times is not going to cause any antenatal consequence or even postnatal consequence, can be seen in normal babies. But right aortic arch, about 5% of these babies would have 22q deletion, so Crichton syndrome, because of which there is relevance of it. So, you know, we can say in the absence of that, prognosis can be good, but actually, if the baby has that Crichton as well, then of course the prognosis would be very varied with neurological implications. So then comes in the discussion about, would you like to have an amniocentesis to rule that out? Okay. This is a picture of double outflow tract. Now, again, you don't have to try to understand this, but I'm just showing that instead of crossing over the two large arteries, two great arteries, instead of crossing over as they come out of the heart, they are laying parallel to each other. And just take my word for it, they are doing that. But this is a surgically correctable condition, and babies obviously, sometimes these babies can be born in Reading as well, in DGH as well. It depends upon whether the lesion is duct dependent upon or not, or are we expecting that suddenly as the circulation changes from fetal to a child circulation with the lungs coming inactive, is there an expectation that everything will fall apart, or can the baby, you know, will the mechanism stay the same? If it will stay the same, then they can be delivered in Reading and then be transferred afterwards for an echo to Oxford. But otherwise, postnatal surgery is highly successful for conditions like these, or transposition of great arteries. Okay, this is a picture I suspect that you can see there is a problem going on here. Don't worry if you cannot, but I'll just point out to you, there's the heart, like looking not quite like this, how we are used to thinking heart looks like, but of course, a little bit like that. There's the apex of the heart. This is the base of the heart. There's the two atria. These are the two ventricles. And immediately what we can see is that this is the right side, which is way bigger than the left side here. And if we did more detailed examinations where we look at the blood flows, we will notice that not much blood is flowing into the left side. This is hypoplastic left heart. Of course, that has a poor prognosis, and for practical purposes, or let's say when I started doing fetal medicine, it was considered to be a lethal abnormality, but now not quite so. There are more and more couples that I'm noticing who are continuing with these pregnancies. The truth is that these kind of hearts will need, they're not called lethal now, but they are dependent upon heart transplant, because that is the only final solution. There will be multiple surgeries required for the baby up until it reaches perhaps teenage, which is when transplant can be considered with its, you know, complications and problems. And you can see why that can cause a lot of distress to couples, that very serious problems, but with even some hope can make it very hard for them to make any decisions about the pregnancy choices. This is an AVSD. Now, AVSD is which is atrioventricular septal defect. You can see a little gap here. Now, AVSD is a very good prognosis from surgery point of view, but 90% of these babies would have Down syndrome. So, you know, when you diagnose AVSD, not so good, because very high chance that the baby has Down syndromes. But if you do an amniocentesis and the result is normal, then very good prognosis. So can you see how the couple might have to go through like a lot of ups and downs during this diagnosis, and not know, and there'll be a huge time period of not knowing whether this is going to be a good outcome or bad. And this is, I keep repeating this because this has a huge relevance, especially on their mental state, emotional well-being, and also for you, because you might be seeing these couples outside of fetal medicine, perhaps in your clinics, in the assessment unit or elsewhere, where realizing that they don't know exactly what the outcome is, and they are confused and what could be their needs and what could be the dilemmas, and that one case is not the same as the other. So just because you perhaps saw another couple 2 years ago with ABSD, which everything was completely different, what was said to them, doesn't mean what is being said to this couple is wrong, but just knowing that perspectives are different. Postnatal surgery happens in Southampton. I'm just aware of the time, so I'm going to go through this very quickly. Postnatal surgery for our babies happens in Southampton, and results are varied, as I've already said to you. Prognosis can be very good, as is for ABSD, but not so good, for example, for hypoplastic left heart, which is only rescue surgery with palliative until transplant. Some lesions are duct dependent, and duct dependent lesions are the ones where we have to keep the duct open. So we keep the fetal circulation going. We keep the ductus arteriosus open by giving them prostaglandin infusion. Hopefully we don't have to do that, and the baby is born in Oxford. But if we do, then our pediatricians are aware. We have combined clinics with pediatricians. We make plans. Our neonatologist creates a very lengthy plan, detailed plan, and a copy of that is kept on special care baby unit. So if this baby comes in, mother also has a copy of that letter, and then that plan can be followed. And as long as that plan is followed, the baby, either intrauterine or extrauterine, can be then transferred safely to the appropriate unit. This is spina bifida. If you look at my arrow here, that's a cross-section of the baby's pelvis region. And just over there, you can see that's an open neural tube defect. And there's a little bit of a kind of slightly coronal section here. There's a spine, and just over there, you can see this open defect. And this is the head or brain of this baby whose spine we saw. You can see a huge ventriculomegaly here. You can see the shape of the skull is abnormal here. This is called lemon-shaped skull, which is associated with spina bifida. Now, spina bifida surgery, intrauterine spina bifida surgery is now offered in UK, is in UCL, and in King's as well. So now that is again another a huge area where confusion happens for couples as well. I mean, it's amazing that these things are being offered, but also being mindful that that also creates a lot of dilemmas for couples, because surgery, although it is available and has been shown to have very good prognosis with improving mobility to even levels of 80% chance of improved mobility, but causes a high risk of preterm birth and a huge classical scar on the mum's uterus. So if this is their first pregnancy, what are the implications then on future pregnancies? So, you know, there's a very careful counseling at the moment, very careful selection of patients as well. So it's not that, oh, we can have surgery. It's just that, yes, we mention surgery, but that it is still at experimental research levels. And if you're very interested, we can arrange for you to have discussion with appropriate people we definitely are not the right people to counsel about it in detail. In the beginning, yes. Okay, again, oh yes, and spinal bifida surgery, remembering that it can reduce the risk of exposure of spina bifida to the amniotic fluid. It doesn't take away the risk which is caused by the neurological stretching that happens because of this defect per se. Of the time, this is a baby at 12 weeks. We're measuring a nuchal thickness here, and I suspect that you're all aware of the fetal trisomy screening program, which offers a 12-week scan for all fetuses, where we can talk to them about whether they would like to be screened for Down syndrome, Edwards and Patels. And if they would like to do that, we measure the nuchal thickness, which is basically the fluid at the back of the baby's neck, which is what is demonstrated here. And then they have a blood test, which studies H3G and PAP-A levels, and then we join it all up, and a risk is calculated for Down syndrome, Edwards and Patels. Now here you can see when nuchal thickness becomes very high, this is how it starts looking as. Can you see the fluid here? It extends all the way, even to the top of the baby's head. And sometimes you can see it covering all over, even the tummy. So then that is called skin edema rather than high nuchal. Okay, so the reason screening exists for Down syndrome is because Down syndrome, 50% of babies with Down syndrome will have no anatomical abnormalities. So screening, the anomaly scan will be completely normal. So remembering that, and it's only screening that can pick up the Down syndrome. But even that has only a 90 to 95% sensitivity. So there are some babies, and I'm sure you have come across some, that are born undiagnosed, which is unfortunate, but that is the state of screening program at the moment. And very importantly, somebody in one of my clinics once said to me that they were surprised how many people, I don't remember, how many people declined screening. And I would say that that is a sign of a good screening program and good counselling. We take pride in that about 20 to 30% of our women decline screening. And we think that that is because we are giving them proper choice. If Brexit divided the country 50-50, I don't see how Down syndrome screening shouldn't divide it at least 20-80. Not everybody wants to go through the screening program, and screening program has false positives, has the effect of causing unnecessary anxiety, but also equally there is enough proportion of our population which may not be interested in knowing or not knowing, because for them a termination of a pregnancy is not an option. So actually giving equal opportunity does not mean providing screening to everybody. It means understanding whether they want it, providing it to those who want it, and ensuring that those who do not want it do not get it. Okay, 50, I have 11 more minutes. So management, let's just go through this and see what we haven't covered. So we have a suspicion of abnormality because we have a 12-week scan, we have a 20-week scan, which is done by sonographers, and they have certain parameters that they need to look at, very strict guidelines, national guidelines, for which they are quality assured on regular basis, and they do all these set views that they're supposed to capture and keep images of. If any suspicion of any abnormality, they refer to fetal medicine, where confirmation of the abnormality is done, and then at the same time searching for other abnormalities, because that can have a relevance on the outcome of the pregnancy. And then trying to search for cause, which can include invasive testing, which can include non-invasive prenatal testing, torch screening, genetic counselling. Discussion of prognosis, as we have been going through individual cases, so of course it will be individualized. And then tertiary center referral if required. For things like minor renal pelvic dilatation, we wouldn't do tertiary center referral, or for even cleft, to be honest. But for abnormalities that require tertiary care, there will be tertiary center referral, which for us is John Ratcliffe Hospital, and pregnancy options, which would include continuing with the pregnancy, a second opinion, or termination of pregnancy. Multidisciplinary team meetings, we have weekly in-house and weekly regional level MDTs at which we discuss all the ongoing fetal abnormality cases on regular basis, get each other's opinions, any other tests that need to be done, and you know, anything else that comes up from it, or women's choices, and just addressing everything that is needed for the couple. Support, very important, informing the community midwife, GP, about this, of offering support through ARC, through our fetal medicine midwives, and via GP for counselling if that is what might be needed for the couple. And advice about future pregnancy. Mostly, as we said, recurrence rate is, will be dependent upon the abnormality, but overall about 3 to 5% chance. So we always have an open access to anybody who had fetal abnormality. We have an open access for future pregnancies to follow them up in fetal medicine so that we can reassure them, because here anxiety can become a bigger problem than the chance of this problem happening again. So just being mindful of that. And approaching the next pregnancy a bit more sympathetically and a bit more inquisitively. For termination of pregnancy for medical reasons comes under clause E, which does not define things very clearly, leaves it open to the clinician's discretion, really, saying that significant risk of substantial disability. If that is the case, then a couple can be offered a termination of pregnancy. There is no defined gestation, note that, although traditionally 24 weeks is considered to be the gestation after which termination of pregnancy, or before which termination is offered. But that gestation is for other clauses more than for clause E. So if there is a significant risk of substantial disability, a termination of pregnancy would be offered. But beyond 24 weeks, although medico-legally only 2 signatures are required, we would always consult our tertiary centre, and would probably take an MDT, like with a pediatrician and fetal medicine consultant, obstetrician, tertiary centre, and yeah, we would take a lot of people's opinion before agreeing to that, and have an agreement from tertiary centre before agreeing to a late termination. Who is the patient? Fetus, mother, couple, family. I could talk about this for an hour, but I'm mindful of the time. We have only 6 minutes left, so I'm going to leave you with this picture in your mind, just remembering that when you see a baby or a mother who has fetal abnormality, who's known to be carrying a pregnancy with fetal abnormality, remembering that all of these are our patient really to some extent, and that we need to be looking after all of them. And issues faced with diagnosis, of course, anxiety, perinatal and mental health support or lack of support, mainly because not many people go through this, so you don't know who to ask. So sometimes we are the only people that really can give them any sensible advice. The stigma especially around any abnormalities, and self-inflicted stigma, because the first thing that every woman, I can guarantee, thinks, and also the first thing that they ask as soon as you give them an opportunity is, what have I done something wrong that this has happened? So, well, I suppose that's the next lot, which is the guilt. And then loneliness, because they either have not known anybody who has ever gone through this, or others have gone through it and never shared it, especially if they have terminated the pregnancy. So you can actually feel quite lonely. Who do you talk to? And then moral and ethical dilemmas and disagreements. Disagreements is a very important one here because we do see this is the biggest problem that I face, well, not the biggest problem I face, but the one that I find most difficult, most challenging to deal with is when husband and wife or partner, they are divided in their opinion about what should be done. Of course, the woman is our final patient, so we take their choice. But we are always mindful that actually when she is taking that choice, it is at the end of the day the father's child as well, and how this is going to affect them emotionally, we can only imagine. And so, and the moral and ethical dilemmas, and I said to you, the more and more services are advancing, we might think this is all brilliant, but remembering that this probably causes more ethical dilemmas for our couples, because where spina bifida surgery was not available before, they didn't have to make that decision. Now, yes, we can offer surgery, but it could have implications on so many things in their life, in their uterus, risk to the mother, risk to the future pregnancies, or risk of preterm birth, which could change the scenario completely for this couple. Remembering that those are unmeasurable comparisons for any couple to make. Even for us as a medical professional, it's immeasurable, all this. So how difficult it must be for the couple. So actually, sometimes by offering more, although we are doing good and we are progressing and there's no reason to not do it, but still remembering that that can actually cause more problems morally and ethically for these couples. And then equally, then the timing of diagnosis can be quite difficult as well, because as we said, that if we are making amazing diagnosis these days with whole exome sequencing and everything, but by that time, sometimes these babies are 27, 28 weeks. People are very differently attached to the pregnancies once they go into third trimester. So remembering that as well. Lack of time. I don't know whose lack of time I'm talking about. At the moment, I think 2 minutes left for this one, so we'll switch that one. We'll leave that one on the side. Concern about future pregnancies, uncertainties, percentage diagnosis. So remembering that all these things are going on in these couples' mind. What is your role? Very important slide this is. You cannot help the fetus, but you can help the mother, the couple, and the family. Remembering these things, it is a complicated situation, but there is no need to avoid it. We can accept that it's complicated and maybe beyond your field. The most important thing to do would be to come clean and say, okay, about this bit, I don't know, but I can ask, and not shying away from it, not shying away from accepting that maybe I don't quite know the details of it. And also important here is respecting the decision of the couple. Say if you, in your opinion, it might be a mild abnormality and the couple have decided to terminate the pregnancy. We don't know what their circumstances are. So not judging their decisions. Equally, we might think that this is a very severe abnormality and we know that the prognosis is very poor and this baby is going to not have a very good quality of life. Or even we have had lethal abnormalities recently where couple have decided to continue with the pregnancy and they say, we just want to hold the baby and see the baby. At the moment there is a baby that I've just been talking about who said that we want the baby to have some time with God before they pass away. And, very much respecting that and allowing that. So we are all here for facilitating whatever our parents' choices, and respecting those choices is very important. And you can always ask us, fetal medicine midwives, who sit in a corner in the room in antenatal clinic, and fetal medicine doctors, Surabhi, myself, Shivani, Bryn, you can ask anybody for any advice, any help if you don't know. And the woman needs care and support. So quite often we see in fetal medicine that once they are fetal medicine patients, everybody stops taking their blood pressure, urine, everything. The woman does need care, and we are looking after her fetus for her and her emotional needs, but there are other physical needs. Please do carry on doing their thyroid function tests and blood pressures and ECGs or whatever it is that they need. So routine antenatal care. There we go. I finished somehow exactly at 3. These are the resources. I think the slides are. Is it right, Belgian? The slides are being sent to them so they can copy this resource.
Yes, if you send it to me, Saruchi, then I'll send it out to everyone.
Yeah. So, but otherwise, Fetal Anomaly Screening Program has very good resources. So you can type in, if you type in FASP guidelines into your Google or whatever it is that you use, then it'll take you to a beautiful place where all the screening programs, fetal anomaly screening programs, and their guidelines, their quality assurance checks, and all the parameters are there. Good place to learn scanning as well. Thank you.